arms of research, the preclinical laboratory, basic laboratory sciences, the clinical arm, and the epidemiological arm of research. And then we talked about the evidence-based practice where you as the clinical expert will use your expertise, the resources or facilities in your clinic, the patient, what the patient wants if they do not want a surgical procedure, and you will take all of that and look at the literature, what's out there new, what is stated or suggested to do to treat your patient's condition. You'll put all that together to develop a treatment plan for your patient. So that is what we're going to talk about in terms of biostats, why we need to understand it, and some general foundational concepts about biostats. And so again, I want to mention this information is not testable. This is a resource for you guys to help you for this course do your assessments, and hopefully it may be useful for your capstone project. So when you guys, I don't know if you've started developing your PICO question, you may not have, totally fine. You are busy studying, that's understood. So when you develop your question and you start to pull articles to during your literature review, you're going to ask these questions about the research. What type of data was used? What type of statistical methodology was used? Was it significant or not? And was it clinically significant? So we're going to talk about all of this information in this lecture and in the next lecture in this class. So biostats will help you as a clinician decide whether or not your study results are random or if they actually have clinical value. And so that's why we use biostats. They help us determine what study design to use. And of course, we use them in our data analytics, and then we make a clinical decision about how to treat our patients based on the biostats of that paper and what was found in the literature about our specific topic. So when looking at biostat, there are some certain terms that we need to understand. They're foundational to understand biostatistics, and they're variables. So if you asked the question below here, does smoking cause lung cancer in the population, if that was your PICO question? Of course, there's some other variables to consider, but the independent variable is the variable that you as the clinician or researcher, you're manipulating that. The dependent variable is the outcome. So you want to know, is the smoking cause cancer? You're trying to find a causal relationship between the independent and dependent variable. There are also some other variables, covariates. Those variables may or may not affect the outcome, but they're usually accounted for in a study. A good study will try to normalize gender and age, and they do this by either stratifying age, meaning they look at certain groups within the smoking sample population and the lung cancer population. So they age match groups. They look at 46-year-olds that smoke and 46-year-olds that don't smoke. That's ways to kind of normalize for the covariance. Then you have a confounding variable. Confounding variable kind of distorts the relationship between the independent and dependent variable. A confounding variable in this question here is that there is an association with smokers and drinkers. So you would want to extract the smokers that drink from your study to find any specific relationship with smoking and lung cancer. Any questions about that? All right. So in terms of the data and the, yes. The actual drinking itself. The confounding variable would be that drinking affects the drinking can affect the lungs as well. So if excuse me, if you drink and smoke, there may it may the drinking may exacerbate any effects you see on the lungs. So you can still include those in your study, but you would want to separate out the smokers and maybe have a smoker and drinker population to see if there are any differences between the lung cancer, like if one is worse than the other, if there are other symptoms involved. Uh, Yeah, so I think you said, is it confounding because they're statistically significant? So can be, but that leads to what you mentioned before. Bias also affects study design, and we're going to talk about that a little bit in this lecture and tomorrow as well. Those don't have to uh, affect statistics directly, but that is also a very important consideration. And at all steps or all processes in the study, bias can be interjected. So, was there another question in the back? Oh, somebody was just stretching. Okay. All right. So, the different types of data that we look at are continuous and categorical and continuous. So, from lowest to highest, lowest are the categorical data. You have nominal and ordinal. Nominal data is grouped. There's no uh, there's no ranking. It's unordered categories. You can't rank blood type. You can't rank gender. Ordinal data would be that pain scale. You guys know when you go to the clinic and they say, on a scale from 1 to 10, what's your pain level? That would be considered ordinal. It's ranked, but there is no true interval value between the rankings for this type of categorical data. Ratio and interval data are continuous data. These data have defined intervals. Interval data include temperature, also like number of visits to a hospital, but temperature doesn't have zero value. Ratio data does. So ratio data is the data that most clinical research studies or most studies in general, we look for ratio data. Blood pressure, weight, A1C levels, that's all ratio data. And that, of course, those values have true intervals in between each numeric, and they also have a true zero. So these are continuous data, these are categorical. They are all used in biostats depending on the particular question you're asking. So after we decide our variables, whether or not they're categorical or continuous, then we need to organize our data and look at or summarize our data and look at any central tendencies. And that's descriptive statistics. That helps us determine the center point of our data and like how our data is shaped, and that gives us some information on how to proceed in our studies. So with descriptive stats, when we use statistics, we are pulling samples out of a population for a particular variable. That variable within the population as a whole is called a parameter. So you guys, clinicians, me as a researcher, we use statistics because, of course, we can never measure the entire population on a certain variable. We have to pull out a sample. So in descriptive statistics, we're looking at measures of central tendency. mean, median, and mode. Here in figure A, we have a normally distributed Gaussian curve with two tails. In a normally distributed Gaussian curve, the mean, median, and mode overlap. We know mean is the average value of all of the measurements. So we take all the measurements and we divide that by the total number of measurements. Median is the 50th percentile mark of our data, and mode is the value that appears most in our study. Questions about that? So sometimes the data is not normally distributed, and we can have a negatively skewed Gaussian curve shown here where the tail is, there's a tail only to the left, and that means that there's a unusually high value of negative scores pulling the mean, median, mode apart, as shown here. Conversely, the positively skewed data is the opposite. There's a lot of positive value, so you have a positive tail to the right, and again, the mean, median, mode are split. So in cases, if you ever are doing research when you have non-normally distributed data, you would look at the median instead of the mean value. You would take the median and base all of your future studies on the median, because that is giving you a more accurate representation of what is going on in the population. For descriptive stats, we also look at how the data is distributed in a frequency table. This is a scoring table that gives us percentage values of particular scoring within certain ranges. And then a histogram is the same information in a visual representation. So if we take this frequency distribution table, scores that were between 5 and 9, there's 1, and that's 3% in this study. And so if we look here, between 5 and 10, there's only 1 value. So the frequency distribution and histogram are giving us the same information. One is just the numerical representation. The other is the distribution. So that's giving us the pictorial representation of our data. And we know the N value is the total number of scores within our sample population. So knowing the central tendency and shape of our data, that's a good start, but that doesn't give us the full picture of what's going on in our data. So if we look at these two groups, this could be any type of study. These two groups, they have an N of 8, so 8 measurements for both groups. The mean, median, and mode are the same for all three, but the standard deviation is different. And the reason why is because standard deviation is much higher for group B, and that is because the data is more widespread, it's more variable. There's a dispersion of the data points around the mean. For group A, the standard deviation is more tightly clustered, and that is because the data is, all of the measurements were close to that mean value. So you would never need to calculate the standard deviation, but they're commonly used in studies along with the standard error of the mean. The standard deviation measures how much a score varies around the mean, and the standard error of the mean, that gives us information about the precision of that sample relative to the population mean. So if our standard error of the mean is a low value, that means that value means that we are likely looking at a good representation of what the value is in our whole population. Yes? No, that's a good question, and we're going to get to that. Very good question. It's a range value. but we'll get to that. Yep. So the simplest variability measures are of a range are the simplest measures of variability are range. We know that is the difference between the lowest and highest point. Also percentiles and quartiles, and we know about percentiles and quartiles from standardized exams, any exams. Quartiles break those percentages up into quarters. And then we have interquartile, which lets us see the middle 50% value of metric as shown here in these box plots. But then you also are able to see the full range of scoring for each of that. So you see where the middle 50% lies and the range value for a particular statistic measurement. What are your questions? Yes. It is. It's the mean. Yep, yep. Good question. Yeah. You're just able to see how widespread it is in addition to the middle 50%. That's why some studies like this, because they want to see how variable the result is for a particular statistic. So, yep. So this understanding normally distributed data is a key concept for statistics because most biological research falls using normal Gaussian curve as shown here. And in that curve, here's the mean, median, and mode, the two tails. For normally distributed data or for a normally distributed statistical measurement, most of a population will fall within 68%. So they fall within one standard deviation of the mean. So normally distributed data follow the 68, 95, and 92%, 99% rule. So most people will fall within that 68%. Then you have the 95% will fall within two standard deviations or z-score of +2 or -2. And then we'll capture almost everybody in that population within 99% of a normally distributed Gaussian curve, which is 3 standard deviations from the mean, median, and mode. And so as clinicians, you guys might have patients that fall out of the standard bell curve. Thank you. The standard bell curve. And so that doesn't mean that they're not necessarily healthy. That just means you may need to monitor whatever metric falls outside of that curve or this normally distributed curve. Questions? So Dr. Grossman was a professor of statistics for a long time, and he stated that a statistician is a person who lays his head in an oven and his feet deep in the freezer and says, on average, I feel comfortable. So basically, he was saying that we use descriptive statistics to give us a data summary. We look at how the data centralizes what the mean, median, and modes are, but that doesn't always answer all the questions. And so the mean tells us the center, the variability or the dispersion of our data tells us the truth of actually what's going on in the population. And so for descriptive statistics, that central tendency is only the starting point. We have to move to inferential statistics. Inferential statistics is the use of probability and sampling error to account for some unknown variable or unknown metric in a population. And so, because we cannot use that with descriptive statistics alone, we use inferential statistics to test a hypothesis using probability. That's the likelihood an event will occur or not. And sampling error is the error of the ability for an error to result in us pulling a sample out of the population, measuring that sample for a certain variable, and getting a different result than what we see in the population. An example of this is a surgeon has been performing a procedure for about 30 years. He has a success rate of 75%. That is his population. But if we sample 20 of those patients and their success rate is only 60%, then the sampling error would be minus 15%. So we expect sampling errors to occur because we're pulling samples out of the population because we cannot test the entire population on any metric or variable. Yes. Yes. Yep. Yeah. Go ahead. 10 minutes. Right? So when we're using inferential statistics, we're testing probability, and probability reflects long-term expectations of what we expect a population to exhibit. And so that's why we see the difference between the 75% versus the 60% due to the sampling error. So we always expect to see sampling error when we pull a sample out of a whole population because we didn't test the whole population. And so because we expect to see a sampling error in a population, we have to conduct hypothesis testing. And that basically is going to tell us whether or not the differences we see in our population, is it due to random chance or is there an actual true difference? And so there's two assumptions that we make: the null hypothesis and the alternative hypothesis. Null hypothesis means that there's no difference between the groups that we're studying. So the groups are equal, there's no difference. So if patients with limited shoulder mobility were given mobilization treatment, which is a PT exercises, their mean external rotation of their shoulder would not be different for the treated group versus the non-treated group. That would be a null hypothesis, no difference between the group. The alternative hypothesis is what we as researchers want our results to be. We want there to be a difference between groups after treatment. And so if the null hypothesis is, if there's no difference, then we retain or fail to reject the null hypothesis if there's no difference between groups. If there is a difference between groups, we accept the alternative hypothesis and reject the null hypothesis. So how do we determine if there's an actual difference or if the results we see are due to random chance? We do that by using the p-value, and the p-value is basically the probability of something occurring or not occurring. And so we set alpha, that's the threshold that we set of the risk that we're willing to accept that the difference that we see is due to random chance or actually a real difference. We set that to 5% or 0.05 as our maximum risk that we're willing to accept. So if a p-value is less than or equal to 0.05, we deem that statistically significant. If it's greater than, if the p-value is greater than 0.05, then of course we would retain or fail to reject the null hypothesis because that data from our sample was not statistically significant. But we can never prove whether or not a null hypothesis is true or not. We can only say that from the sample that we pulled, we didn't see any differences. And that's based on us not seeing any differences can be based on a number of variables. So it could be due to the variability of that population, And so we can never disprove a null hypothesis. And so when you guys are working on your capstone project and your papers in particular, what we want our papers, and even some published papers, they try to sell their research and make it seem like it's the best thing since sliced bread. And so they will use language that's not appropriate. Like you can never say, these results prove or these results indicate. You can't say that in scientific research. That's a good way for people to be like, oh, he doesn't know what they're talking about, because we can never prove anything by doing a sampling of a population. We can only say these results suggest, or based on these findings, we hypothesize this. You can't use definitive language when you're writing. So you guys probably forget this, but when you're writing your papers, I'll read some of them if you guys want me to. Can't read all of them. Nobody laughed. Okay, I'll keep going. No, to make sure that you don't use definitive language, because you cannot use definitive language in a sampling study because you didn't test the whole population, so you don't know whether or not that is true for the entire population. So again, there are levels to p-values. 0.05 is a 5% chance. There's also 0.001 that confirms that the results we see are highly unlikely due to chance, and that can be due to a number of factors. Either we have a very large sample size, or we had a very large effect size. An effect size means that there's a huge difference between our untreated group versus our treated group. So that would give us a large or a very low statistical significant value. And then again, if it's not significant, that could mean that the data is highly variable within a population, or we haven't tested enough sample numbers, or our N value is too low for this study. And so that N value is a very important consideration when conducting biostatistical analysis. We have to typically, the larger the N value, the more the consistent results, that will more likely let us find a statistically significant value. And so how many subjects were studied, that follows the law of large numbers. That means that the larger the sample size, the more you can trust your results, meaning the more you can say that you have accurately rejected the null hypothesis if you see a difference in your study. So these variables affect statistical significance, but they do not affect clinical significance. Clinical significance deals with the patient care specifically. It deals with the individual patient care. So if you have a patient that you are prescribed a cardiovascular drug to lower their cholesterol, and their cholesterol drops from 230 to 225 consistently, that could be statistically significant, but it's not clinically significant, because anything above what value still puts a patient at a cardiovascular risk. You remember? Anything above 200 for cholesterol still puts, you guys are looking at me like, what? That was block one. I just threw that out there to see if you guys remember. It's okay, you don't, geez. Looking at me like y'all want to kill me. Okay. Yeah, so anything that's not below 200, in this case, any drug that lowers it, but it's not below 200, that might be statistically significant, but it's not clinically significant to the patient, because they are still at risk for a cardiovascular event. Does that make sense? Any questions about that? So confidence intervals. Confidence intervals they're more meaningful than p-values, because confidence intervals, and they're usually set at 95%. That is the range of where we think the actual population falls within a particular statistical variable that we're measuring. And so many of the studies, depending on what type of PICO question you ask, will use confidence intervals or p-values. Some will use both, and there are some other metrics that we're going to talk about, some of them today. But generally, confidence intervals are more preferred than p-values, and the smaller the range or the tighter the range for the confidence interval, the more likely, the better the results are, because that means you have a more narrow range for where you anticipate or suspect that population to fall for that metric. So if a confidence interval, if 0 occurs in a confidence interval, that means that there's no difference because you hit the value of 0. So that means that there's no difference between the groups, and you would retain the null hypothesis in this case. So there are some errors in hypothesis testing. Type 1 error is a false positive. You say that there's a difference when there's not. Type 2 error, you miss a difference that does exist. So type 1 error, convicting an innocent person. Type 2 error, letting a guilty person go free. Or, this should make it more clear. Type 1 error, you're pregnant. Well, you can't ever be pregnant, so that's definitely a false positive. And type 2 error, she's missing pregnancy in this patient. I feel like I could have been in this picture because I do look pregnant, but that's neither here nor there. Hey, if y'all are not going to laugh at me, I'm going to laugh. Shoot, I want to laugh. So power analysis is another important statistical application used, and that is mathematical calculation that helps you determine the sample size, usually set at 80%. You set your power at 80%, and that confidently lets you know that if you've tested this many people in your sample, you are 80% confident that you can reject the null hypothesis for that particular metric. So in general, the more people, the more N you have, the better the power. And so I mentioned the effect size. The effect size is the magnitude of difference between the treated and untreated group. So if the effect size is large, you're going to have a highly statistically significant p-value more than likely. And that could be due to just a large difference based on that particular parameter. If you're using a drug, a large difference between the drug, or if you have a large sample size. Sometimes a large sample size can drive a large effect size because the sample size is tightening up your standard deviation and standard errors. So that's making the differences between the two groups even more pronounced. Yes?
So I noticed that we're not including the formula used to calculate these. Is that because it's very convoluted? We don't know that?
Yes, and you would never need to do that. You would use an equation. I tried to find it, but I couldn't even find it. Like the calculator. I was like, how is this calculated? But I wasn't able to find it in the textbook. So it's a lot of steps that you guys will never need to know unless you decide to do an executive MBA program. One of my friends is doing it. And when he told me he had to do it, I was like, never mind. I'm not going to tell my class that. Yes, sure.
That in the research that we're looking at, we're looking for them reporting these things like, oh, this is our confidence interval.
Good question. Absolutely, you're looking for confidence intervals. Not all the study types will have them. If they do, it's generally deemed a better study. You're definitely, if you see power analysis, which you will, and I think we're going to talk about a study when I do my when we do the sample assessments that I'm going to give. There's one study I think they did power analysis that is just improving the quality of their study. So if you see that, you know they've taken some extra steps to give you good data. Very good question. Yes.
The effect size within like units of the variable that the study's around. So it's like increased blood pressure, like 20%, something like that.
Correct. Yep. 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 Whatever variable it is. Yep. Any other questions? All right. So now we're going to talk about some of the different statistical applications you guys might see. Some of them are kind of research specific. The first ones we're going to talk about, you're likely to see if you have an epidemiological type question, and it is prevalence. So prevalence is looking at the snapshot or one point in time of if you have a defined population at the onset of a study, you've developed you have a cohort, you test them for a certain disease. The people that have the disease versus those that don't at that baseline, that is the prevalent cases. So that's at one snapshot in time. Then what you do is you look at the group that does not have the disease and you look at them over a period of time. In this example, 1 year. There are some studies that do 10 years, 15, even 20 years. And then they look for the people who develop the disease and those that did not have it at baseline. And this is incidence. So prevalence is at one snapshot in time is an incidence is those who develop the disease over time. So prevalence and incidence can change. You have baseline prevalence of a disease. If there's a high morbidity of that disease, meaning that people stay sick longer and there's no cure or they don't die, then incidence can increase, or incidence will increase the prevalence. Sorry. So you start with a baseline prevalence as more incidents occur and people are not being cured or dying off, your prevalence will increase. If people are cured or they're dying, prevalence can decrease, and it depends on whatever disease it is. So there are screening tests that are used to measure these diseases to determine incidence and prevalence. This was done a lot during the pandemic. All those screening tests used to determine whether or not a person had COVID-19, SARS-CoV-19, but there are also a number of other screening tests used. There are certain criteria that screening tests must have. They must be able to diagnose a serious condition that has a has a moderate to high sickness and death rate, and it has to be a condition that they have a treatment for in the early stages. So colonoscopy is one example of a screening test that um, they of course the GI docs will look at your colon to see if you have polyps. If the polyps are malignant or not, they can be removed immediately. If you have a lot of them, then you have the option to undergo chemotherapy. That's one example of screening tests. Another example is the hemoglobin A1C test that middle-aged people like myself have to take. I mean, I'm middle-aged. Like, I may not be pregnant since you guys didn't laugh at that, but I'm definitely middle-aged. But so if you are obese and the Army considers me obese, I have to be tested for that. And so that test basically will determine your hemoglobin A1C levels. If they are normal, you're good to go. If they are in between 5.7 and 6.2, that means you're pre-diabetic. Then you will be meeting with a doctor and them telling you you need to stop going to Fogo de Chao and eating all the gummy bears and stuff. True story. I'm not pre-diabetic, no, but if I was, that's what they would tell me. And then if you're diabetic, of course, there are treatments. There are drugs that the doctor will put you on. So that's another example of a screening test that's used. So for screening tests, these tests should have a certain level of sensitivity and specificity. Sensitivity tells you how well the test identifies a sick person. Specificity tells you how well a person rules out somebody that is not sick. So there are some tests. The rapid strep test has a pretty high level of sensitivity and specificity. So they're doing both at the same time. I believe their sensitivity is about 90% for the strep test and their specificity about 95%. So they're pretty accurate at detecting those that have the condition and not not identifying somebody that incorrectly diagnoses the patient. So there are also some other commonly used statistical applications that you will see. You might see independent t-tests. That's when the mean values of two groups are measured against each other. And that could be looking at two different drugs. The paired t-test is a before and after measurement. So if you want to see how sample responds to blood pressure medicine like um, lisipronil, you would measure their blood pressure, give them the drug for a certain specified period, and then you would measure their blood pressure again. So you're looking if the drug decreased their blood pressure over whatever duration the study looks at. ANOVA, or analysis of variant, compares three or more groups. So you're looking at the means of three or more groups. If you have three different types of medications that have different mechanism of actions, you might use ANOVA. And then chi-square test looks at categorical data. So you might want to measure whether or not you have patients that have chronic obstructive pulmonary disease, and you might want to say who smokes that has the disease, who doesn't. You're looking at categories. And Fisher exact test is categorical data with very small populations. So these statistical applications and all the ones that we've mentioned will be used based on whatever question you're asking, what study design you're using, and we're going to talk about in tomorrow's lecture how particular study questions, what type of study methods or study designs that they use, and there are certain statistical applications that kind of go hand in hand with certain study designs. So the final three statistical applications that we're going to talk about deal with associations, relative risk, which is a probability of event happening or not in a group. Then you have odds ratio, it is a comparison. And then hazards ratio. And so these are used in cohort studies. Cohort studies are a sample is selected and they're followed over a period of time to see if they develop a disease or not, or to see if a drug treatment worked or not. And so here's the formula for relative risk. It's the risk in the exposed group or the unexposed, or the risk in the treated group versus the untreated group. And so the interpretation, if RR is 1, there's no difference between the risk for the groups. If the risk is greater than 1, there's an increased risk with exposure or treatment. If it's less than 1, there's a decreased risk with exposure or treatment. So if we look at a group of people that had headaches, 100 that were given a drug, 100 that didn't, and we determine the relative risk in each group. So the relative risk for the drug group would be 10 got the headache after the medication, 90 did not. So the relative risk would be 10 over 100. That's 0.1. For the placebo group, 20 got the headache out of 100, so that's 0.2. So the overall relative risk is 0.1 over 0.2. That's 0.5, meaning that taking the headache medicine reduces the risk of headaches by 50%. Questions? Odds ratio, similar, but a little bit different. It's looking at the number of times something happens versus the number of times something does not happen. So if we were to look at the same drug and treated group for headaches, the odds ratio is odds in the disease versus odds in the control, or odds in the treated group versus odds in the untreated group. The interpretations are still the same: 1, no association; greater than 1, higher odds; less than 1, lower odds. So for the drug treated group, the odds ratio is 10 over 90 instead of 10 over 100, as we saw with the relative risk. 10 over 90 gives us 0.11. The placebo group is 20 over 80 because we're looking at who got the headache over who did not get the headache. That's what odds ratio looks at. And so that is 0.25. So the overall odds ratio is 0.44. So that means that taking the headache medicine reduces the odds of getting a headache by 56%. Questions? All right, the last metric that we're going to talk about, this is used, hazard ratio is used for time to event studies, so time to relapse, time to death, time to recovery. And so this study design lets us capture the entire amount of time a person or a sample was in a study, because most studies, if a person drops out, you're not able to use that information or that data. This design lets us use that information. So the formula, very similar: hazard in the treatment group over hazard in the control. The interpretations are exactly the same. So in this study, we're looking at a drug that's used for cancer survival. So we have the drug group versus the placebo group. And one important variable in this study is total person months. This person months metrics is what allows us to account for the entire time a person is in the study. So if a person drops out, if a person dies, or if a person is unable to continue for whatever reason, we're still able to include their information while they were in the study. And so here we have the control treated groups. The study was 12 months in duration, and the drug treated group. So the total person months, you would add up all of the months that each patient participated in the study. Over that number, you would divide those that passed away or did not complete the study. In this case, that 5 passed away. So 5 over 94, which is all of the months each patient able to participate in total. So the hazard ratio for the control group is 0.05. You do the same thing for the drug treated group. 4 people died in the drug treated group. And when tabulating all of the months that they participated, that gives you 4 over 97, 0.04. So hazard and treatment group over hazard and control, 0.04 over 0.05 gives us 0.8. So that means that the drug lowered the hazard risk of death by 20% for this 12-month study. Yes.
What if somebody died that's not related to the drug? Is that affect?
That's a good question. It depends on what happens. They may or may not. They probably have some selection and exclusion criteria. So they might have to remove them, and they might not be able to use this at all, um, because typically this is looking like, especially as for a drug they're looking at, that the drug help improve. But if they had to be removed for some other reason, then they probably would have to remove that patient. That's a good question. So when we put all of this together, from the study design all the way to the treatment of your patient, biostatistics are very important because they allow us to analyze data, see if there's a true difference, and if there is a difference, can it benefit our patients? Can we incorporate whatever the literature or recommendations in that article or in that study, can we incorporate that in our patient? And some other considerations in doing this for particular studies is internal and external validity. Internal validity of a study looks at the parameters of the study. Was the study design done in such a way that you controlled for the confounding variables or the covariance, you normalized, you removed, you had strong selection and or inclusion criteria for the study, and you controlled for biases. We're going to talk about biases tomorrow. And then external validity is how well does these findings extrapolate to the general population? If it doesn't extrapolate to the general population, then it's not really a good study and probably not something you would want to use to treat your patient. But those are all considerations. So you must use all of this information, the findings from the data, your expertise, your resources that you have in your facility, and what the patient wants. You have to consider all that for evidence-based practice in order to effectively treat your patients. Any questions? Yes. Um, that's a very good question. So yes and no, because you do want something that is not known. So you just, what you're going to have to do is that when you come up with a question, you're going to have to look to see what you find and like go through the papers. If you're not finding anything, and you can, this is where you sit and talk to your academic advisors and say, hey, I found this, is this enough? I'm not, like, one of my counselee, she did something that I needed to know about. It was about balding. So, and this is a true story. So she wasn't finding any good studies, but unfortunately, that's kind of what happens in research. Trust me, I spent 5 years in grad school and stuff wasn't working. So stuff doesn't work all the time. The studies that are out there are not always well designed. So, but as long as you like like capture what they did, capture their shortcomings, and say, um, this could potentially be something after additional studies. You can use something that doesn't have a lot of data. I don't know if that answers your question, but we can talk offline about it if you want to. But to answer your question, yes, you can, but you just need enough to be able to formulate some type of hypothesis on what you think would be beneficial for treating your patients. If you don't have enough, then you may need to modify your question. So, yes.
Kind of the inverse of that question. If you have a topic and there are several good research articles that like several studies have been done, can we use multiple or do you like? And I guess it also depends on like the size or something like that too. How many studies are we actually getting to look into, or do we just like use one?
You would use, so you need 4 references for your PICO question. Those references, depending on the type of question you ask, those references may reference hundreds to thousands of other studies. So if you have those 4 references, that's all you need to come up with a question, and then of course you're going to be doing more research because you start with the question in the first. That's due the end of this semester. Next semester, you are going to be working on drafting the paper, which is due at the end of next semester, and so you'll be working with your academic advisor. If you find a lot of articles of something um, that you want to study, that of course it can't be something that they have a definitive solution for. It's something that it's kind of something that you're looking for, like maybe a tangent or a parallel offshoot for a condition. Because if it's something that's already well known and well established, then you're not adding to the research. Does that make sense? Yeah. Yes.
How will this be? Where are we? Are we gonna get more information? Type in.
For your PICO, yes. Have you guys had master seminar yet? You in master seminar, Dr. Friccione is going to go over all of that. Yeah. So as soon as you guys have master seminar, a lot of questions will be answered for you. But yeah, in master seminar, you're going to get the rubric, what you have to do, and some more information in terms of how to go about selecting papers and what type of topics are acceptable. In general, topics are topics that you may experience in family medicine are what's preferred, but there's a lot of different topics. You guys have very like a wide range of interest on very important questions in medicine, and so it's a broad like limitations of left and right limits of what you can study. But once you develop a question, you'll just confirm with your academic counselor whether or not that question is feasible to continue forward. Yes. Your academic advisor grades it, and so the first semester it's only 5 points. So the second semester, your draft is complete, non-complete. The third semester is actually for a letter grade, and then the fourth semester, your last semester, you have an oral presentation. So you're just gonna take that paper and make it an oral presentation. It's like 7 minutes, so it's not that long. But you're graded by a panel of 3 instructors that will be asking you questions about your project. Any other questions? All right. I will see you guys tomorrow. Of course.